Well, it's always a challenge to follow the legend, Dr. Russell, but I'll do my best. He's been here many more years. So I'll continue the trend that I started this morning, or this afternoon, other speakers this morning, of emerging therapies that have the common theme of being really exciting and really game changers of diseases that we used to not be able to treat well, to now we can probably treat them, to also being a resource question with very expensive therapies and how we're going to deliver to patient populations throughout the world. And the two examples I'll give are Duchenne's muscular dystrophy and spinal muscular atrophy. And there'll be a similar story, but it's going to diverge in that for one of these diseases, the therapy is quite good, and the other one is really not that good, and we need to move on to the next level. But it really pulls us back into, where you're at in the 21st century, is that you really need to know molecular biology and molecular genetics now to take care of patients, because the therapies are really based on that and what's going on. And I'll review these disorders just so we can understand how the therapies came about. And they really, Dr. Sultan's talk earlier today was a helpful introduction, because it's really about not the DNA, but the mRNA is being modified here. But then for diseases that don't work well, that's the Duchenne's muscular dystrophy for this therapy, there is technology coming that is more DNA modification and even DNA replacement. True gene therapy is happening. And just the buzzword that I'll throw out that we'll talk about near the end is the CRISPR technology. Genomic engineering essentially is something that's now coming to clinical trial, and I'm sure we'll use more and more for, again, everything. So just a refresher, Duchenne's muscular dystrophy and Becker's muscular dystrophy, in one sense, not the same disease, but the same gene. Duchenne's is the severe form, and Becker's is the mild form, and the therapy I'm telling you about is really designed to take one disease that's severe and turn it into a mild version. So instead of having Duchenne's or Becker separate patients, we're trying to think about making it less severe. And this is a pretty classic X-linked disease that most people learn about in medical school and beyond, is that these are boys who are weak. They have the big calves. I'll show you a picture. Their creatinine kinase is very, very high. And in our clinic, a boy being brought in with concern for weakness and not walking with a high CK is almost always Duchenne's muscular dystrophy. It's relatively common muscular dystrophy. And you can do gene testing. You can do muscle biopsy to confirm all these things. And there's some good information that came from the muscle biopsy data looking at this protein dystrophin and antibodies against which I'll show you in a few minutes is really key to thinking about these therapies. And then this is the Gower sign. This is the classic sign of boys who have a hard time getting up from a sitting position. Though it's actually a non-specific test, it really means your proximal muscles of your hips are weak. So anyone who has proximal weakness of their muscles will use their arms to help them get up like he does. But it's just in this age group, in this scenario, Duchenne's is the most common diagnosis. You can also appreciate a little bit that he has enlarged calves too, which is part of that diagnosis. So this is a pretty classic presentation. Boys with Duchenne's like this, while they can walk, they're delayed, and he's a pretty happy guy. They will deteriorate over time as their muscles fall apart. The treatments until recently are pretty supportive, good nutrition, good physical therapy, and the mainstay of treatment is steroids, and through pretty good data, we know steroids will keep boys ambulatory longer, but eventually they all deteriorate and have loss, and they usually die in the teenagers or in the 20s from respiratory insufficiency, and there's also a cardiac phenotype as well. And the Becker type, just in contrast, which we're really trying to do, is turn Duchenne's into Becker as one possible therapy, is those patients do better, but they also have more weakness over time, decades, and then cardiac disease as well. So switch gears now, SMA, spinal muscular atrophy, and this is something that many people know about. It's actually, to my view, fairly straightforward diagnosis, and it's always broken my heart, because these are children at a very young age present with hypotonia, decreased muscle tone, and weakness. Their brain is totally fine. They look at you very engagingly, but they're just very weak and floppy. And we know enough with this presentation that we can diagnose it, again, with genetics. And the gene is called SMN1. And there's another gene called SMN2, which is a key to this therapy I'll talk about. And then there's different numbers of this SMN2 gene, which is also important to the therapy. There's types 1, 2, 3, and 4. And type 1 is the one we mostly think about in pediatrics. This is the one that's uniformly fatal in the first year of life. And if you ever just want to help think about different types, type 1 patients are so weak they never are able to sit. Type 2 are never able to walk. And type 3 is a later onset, and type 4 is an adult onset. So these are pretty severe diseases, and most of what we're going to talk about therapy is really designed at the worst type is a type 1. For neurologists, they don't have any reflexes, and again, we can diagnose it with either a genetic test now, because most patients have this SM1 deletion, which is easy to detect on chromosome 5, but you can also do a muscle biopsy or electromyogram type testing as well. And until very recently, the treatment was just very supportive, and again, it really hurt to make this diagnosis, because these patients would almost all die in the first year of life, and there wasn't much you could do about it. So the challenge is to move beyond the current therapies for both of these is listed here. I'm not going to go through all this, but just point out some of the challenges in the new therapies is Duchenne's is the biggest gene we know about in the human body, as far as I recall. So if you're trying to do a gene modifying therapy or gene replacement therapy, this gene is huge. It's hard to package into some sort of therapy replacement, for example. It's the most common type of muscular dystrophy. It's on the X chromosomes I mentioned, and it's a progressive disease. The SMA, in contrast, is rare, but it's still the most common genetic cause of death in young children. It's a homozygous genetic autosomal recessive disease with these deletions, and again, it's a progressive loss and really poor survival with really no good care. So the answer to this, at least temporarily, would probably be a way stop, is antisense oligonucleotides. And people who follow this field, it's actually probably 20 plus years old. But the idea is take single-strand nucleic acids that can then bind to either RNA or DNA and do something. And the antisense nucleotides shown here have some chemical modifications so they're more stable. So once you inject them into people, because they typically do not work through your gut, you have to inject them into the body of interest. Once they're stable and can be used for therapy. And since it's a sequence, you can design this for any sequence you want in the human gene to target it. So the Duchenne's muscular dystrophy patients, there was a good observation by pathologists. If you're doing a diagnosis, you take a piece of muscle and you use an antibody to the protein. And since it's a Duchenne's and the gene is really severely affected, there is no protein made, and that is actually the diagnostic test. But some sharp-eyed pathologists noted that occasionally there would be a piece of muscle, just a little piece, that has protein involved. And the molecular explanation for this is sometimes when you have a deletion in this huge gene, you get another deletion, which actually sort of fixes it by taking out one frame shift, if you will, and giving it another one. So some protein is produced. So on an individual muscle cell level, the gene can actually recover. So someone thought, is there a way we can exploit this to make the gene that's broken? Can we break it twice to actually fix it, if you will? And they recognized also that a lot of patients, 13%, enough you could think about this, had this problem with exon 51. So the strategy became, how can we deal with this exon 51 hotspot? And that's where these oligonucleotides came in. This is a busy slide, but it tells nicely that you have this sequence that can be taken into the cell of the muscle, and it goes and sits here where this exon 51 exon is, and it can keep that exon from being spliced. So if you think about your mRNA, your pre-mRNA, making a protein, since these patients have deletions in this exon, if you simply remove that entire exon, you can then bypass the mutation, and now you can make a protein. It's not a normal protein, it's smaller, but it's better than nothing. So essentially what this therapy does, and it's been shown to work in cells and some animal models, is again, turn Duchenne's muscular dystrophy into Becker's muscular dystrophy. And this is shown here in some human data where they gave these injections, and on the side was injected. This is the contralateral control with muscle biopsies. You can see the protein appear again. And then from this, it led to FDA-approved trials and actually FDA approval. And this is some of the data, which sounds great, and we read a paper, is that how far can these children walk in 6 minutes? That's actually the main endpoint, the 6-minute walk time. And this was improved in this study with some patients doing a little better and the controls doing worse over time. And then they showed there was a little bit of protein back in the muscle. So based on this, the FDA did approve this provisionally because the data was not great. And then if you ever go to an FDA meeting or something similar in the EU or in Jordan, I'm sure there's a lot of people yelling at each other because people want therapies, and the people who do the regulatory decisions have to look at the data and make the best decision. But you have advocates, and it could be drug company advocates and patient groups, and they were so vocal, they overturned the FDA's initial decision once they said, no, do not approve this drug for muscular dystrophy. It's not good enough. So the FDA approved it, but they said, we'll approve it, but show us more data down the road, which most people in this field think will never happen because once a drug is out and children are treated with it, it's hard to take things away. And continue the theme, this is a $300,000 a year drug, and it has to be taken for life. And other countries have been smarter than the US and have not approved it. The EU said no as well. So this is, again, a good technique. It's helpful, it kind of makes sense, but really for most people in the field, don't think it was a game changer. And again, it's only for that 13% of Duchenne's muscular dystrophy patients who have a molecular defect in exon 51. So for all these reasons, it's very disappointing that it was very expensive and not a great drug. In contrast, the same story, the same approach in SMA has been a game changer. This cutting to the chase, and people probably know about it because it had such good press. All these children who are dying are all alive now if you treat them early enough. It's that dramatic, and it's one of the best things ever in my career. And the molecular pathology of this is based on the fact that this SMN2 gene normally in us doesn't work. And it doesn't matter because we have the SMN1 gene. And it doesn't work because there's a built-in problem with exon 7 in the SMN2 gene. Sorry about all the names. So this same oligonucleotide strategy was designed to fix the bonus gene you have, SMN2, to get it to work by targeting exon 7. And that was done, the same idea again, introduce these oligonucleotides into the anterior horn cells of the spinal cord, suppress this problem with exon 7, and now for the first time make a protein from the SMN2 gene, which is identical to SMN1, except it normally doesn't work. And the clinical trials were here, phase 1, phase 2, and then 3, showed most children responding, doing better over time, having more strength, learning to sit, eventually learning to walk. And 2 children actually died during the study, which is not surprising because SMA is such a bad disease. But from that experience, they were able to take those 2 patients who died and do an autopsy and show that their motor cells, neurons, actually have expressing protein in them. So they proved that it actually worked. And most patients progressed. So this, I'll skip through this in interest of time, but some of the primary data showing this is effective treatment. But again, if you just ask the question, are you alive or dead at 1 year? You can show this drug works. That's not the research question, but that's how dramatic it is. So the FDA in the USA approved this in December of 2016 for all types of SMA. And this, since these drugs are not taken in by the gut, you have to inject them into the spinal cord. So intrathecal injections have to be done several times in the first year and then every 3 or 4 months after. And the drug company, in their wisdom, of course, made this very expensive. So it's about $750,000 for the first year as you load them up, and then the maintenance is thought to be about $375,000 per year thereafter. As Dr. Russell said, these things have to get cheaper, we have to get better. We're getting there, and other countries in the world have followed suit with these drugs too. So that's a great story. It's a game changer. Children who are dying are now living. The other disease, not so much. So what else can we do? And just the last couple examples I'll give you is actually give the gene back now. Instead of trying to tweak the DNA and the RNA, actually give the gene. And there's a whole history of gene therapy trials that have been done for the last 30 years, starting more than that, actually 40 years now. And most of them didn't work because we didn't know how to put genes in viruses and safely deliver them back to humans. There's been several people who have died from this, and there's different trials, but now we're finally getting to a level, and in my field, neurology, and I think it's gonna be true for almost every field, we're gonna get much, much better at gene therapy because there's a virus called adeno-associated virus, or AAV, which can be hijacked to deliver genes, and the AAV virus does not seem to provoke a big immune system response. So this was the AAV replacement for Duchenne's now, and it's gonna be challenging because I said the Duchenne's gene is huge. It's too big to fit into the AAV carrying capacity, so people's strategy has been trying to make a mini gene that can be used to deliver effectively. So again, I think Duchenne's is gonna be very hard to treat, but again, the next step is gonna be gene delivery. And then this is where CRISPR may actually be the work. Now, CRISPR is a technology that uses virus knowledge to change the DNA of cells of people. And there was a huge press till recently with a scientist in China using CRISPR to actually modify the embryo of now living children. That's a horribly bad idea for reasons you can all readily appreciate. But for a therapy, using CRISPR to fix the Duchenne's gene may be the way we're going to go for this approach. And then the last thing I want to mention to you is now gene replacement for the SMA. Why I said that was a great success, it still involves frequent intrathecal LP-type injections of this drug, and it's very expensive. So this gene is relatively small. This can fit into the AAV virus. So there are ongoing and so far quite successful clinical trials seeing if they can deliver this drug once as a gene replacement therapy to be permanently expressed. And that's probably where this is going. And if you think about that and you're a drug company, the current therapy is, again, $750,000 US for year one and $375,000 forever. So you can price a one-time therapy to be much more in their mind because it'll still be cheaper perhaps. So how much do you think a cost, if you haven't heard the news already, of this gene therapy is going? It's not even approved yet, but the drug companies are always throwing out numbers to get people used to the idea. Huh? So $2 to $4 million is the cost of this drug, which I think is now the record for drug therapies it's talked about. But if you had one drug injection that cured a genetic disease for their entire life, then you can start having discussion about whether that's worth it and how as society we're going to pay for that. Again, all these costs will come down, but that's where we're at. So future directions, I mentioned the AAV, these therapies, and then going beyond, again, the oligonucleotide data. So shukran.